I don't have any slides. I probably don't have anything to say, quite honestly. I think it was said by the family and then done so eloquently by some statistics and high-level meta-analysis. So I'm just going to do a little bit of ruminating over a 40-year career of trying to talk about the integration of social and medical care. Couple of full disclosures. First of all, I come out of the social world. My first job in Washington, D.C. was as a presidential management intern with AOA, and that was in the early 70s. I am very strongly committed to the social supports infrastructure in this country. I think it's been undervalued ever since Arthur Fleming actually created the Aging Network, helped to create the Aging Network 45, 50 years ago. There was a vision that there was going to be an infrastructure that supported the kinds of things we were talking about as we heard the family talk about their needs this morning. I also have a doctorate in public health, and I can tell you that public health has known about social determinants of health for the past 300 or 400 years. This is not a new concept. The medical care system has just discovered it, and now somehow they think that they're going to solve the problem. So I would like to be a little bit provocative in my message here. I'd like to actually add on to the conversation of whether these dollars ought to be coming out through the healthcare system and argue that the whole thing needs to be turned on its head, that these dollars need to be building a strong social support infrastructure in which the medical care system works. It's the system of last resort, not the system of first resort. Now, that's my vision. Of course, you also have to be pragmatic in this world. So a lot of the work that I'm doing right now is to try to steal money from the Medicare and Medicaid program so we can put it into affordable senior housing and support the kind of infrastructure that we are seeing in some of the models we're working with, actually allow people to stay in their apartments, stay out of hospitals, stay out of ER rooms, emergency departments, have good quality of life, less social isolation, and live there for the rest of their lives without ever having to transfer to a nursing home. Why is this important? It's very clear when you heard the story this morning that people do not live in a medical care system. They live in the world. For 365 days of the year, they are addressing their social needs. And, you know, if we don't recognize the combination, whether we're talking about spending or whether we're talking about a delivery system that is built around the social fabric of where people live, what they need, how you bring those kinds of needs together and meet those needs, those true functional and quality of life needs, and then where does the medical care and medical system fit into that, regardless of the type of need, whether you're talking about chronic conditions, serious illness, palliative, hospice, end of life. Quite honestly, I think we've created so many categories of illness and sickness that I don't even understand what it is anymore. I don't know the difference between chronic illness and serious illness and palliative. All I can tell you is when the family talked about their needs, they had the entire gestalt of what a lot of families face in this country. And quite honestly, in the extreme, you also had a family that was incredibly rich in terms of their intellectual resources to bring to bear, even though they did not have the financial resources to bring to bear. That is not the average family. Most families don't have a clue at all about what's going on out there. So I think thinking about the investment in our social system, and I am on the National Academy, and I am so unbelievably happy that the Academy is actually addressing these social needs. But we need to think about it much more broadly than just an integration approach. It's a framework approach, which is we start with the social infrastructure. We invest in that. How we invest in that, I think that's a great question. If we have to steal it from healthcare, I'm totally happy to do that. If we have a decision that we all want to pay more taxes and invest in it that way, if we want to have public-private partnerships around that, I think that's great. It has to happen at the local level, and there are communities that are investing significantly in this infrastructure. But the first thing is to have an awareness that the system is totally upside down for people who have serious illness, who live mostly in the community, Even people at end of life. I was just in New Zealand, and I was working with some hospice folks there who have actually brought in OT and PT and all other kinds of more socially oriented therapies for people who may have 2 years of life left, but still have a lot of meaning in their life. And they're working through that till their last breath. Very, very different model there in New Zealand, even at the end of life. So I think it's really important for us to not think of this as an integration, but really more as a framework. I also wanted to say a couple of things about the implications for healthcare payment and the delivery reform that we're looking at right now. I think it is totally misplaced in terms of all the millions of dollars that have been put through the healthcare system to create maybe five, you probably had more than 5 case managers or people that you talk to in terms of who are doing assessments and who are going to coordinate. And every time we add another layer through our healthcare system, we're just adding another one. Peter Bowling, a really good friend of mine who's a geriatric home care doc at VCU in Richmond, tells me that his main problem in terms of going into people's homes and doing very holistic home care visits is that he has to deal with so many case managers, including one from his own plan, that he doesn't even know what the heck that person is doing, that all they do is get in the way. And so somehow we have to figure out how we have, what we talk about in the aging network world, really true single point of entry, which starts with the social system. It does not start with the medical care system. As long as we are still talking about putting this into hospitals, now we're focusing on putting it all into primary care offices. I mean, my primary care physician is fabulous. I'm not going to put all of these responsibilities on her, and we shouldn't. We ought to have a system that can wrap around and build in the medical care system when we need it, even for people with serious illness, whatever that means. So I really think that we have to turn this on its head. We have lost all of our investment in housing. HUD has totally zeroed out the HUD 202 program, which was the only program that supported frail and disabled elderly in this country. We are having a lot of attacks on most of our nutrition programs. We have serious attacks on our transportation investments, certainly at the federal level, but we also see it at the state level. And I think the point of having to spend more money on health care and really putting a lot of pressure on the Medicaid program where there's no money left to pay for anything else is a really serious one for us. In terms of healthcare payment and delivery reform, one of the things that I think is really important is we talk a lot about team-based care. Moore Foundation just had a fabulous meeting on creating a workforce for team-based care out in California. Very, very difficult to get any discussion of social support professionals in teams. The discussion in these rooms continued to be around medical professionals. Maybe they think a social worker is as close as you're going to get to social supports. I do a lot of work on frontline workers. Most of the care that is provided in home-based settings is delivered by aides, maybe LPNs. These are the folks that are the eyes and ears of the system. They are very rarely included in teams. They are not even considered as part of a team. They are sort of like an appendage that's out there in the home, and maybe we'll ask them a couple of questions when if you go and you look at what these aides are doing, trust me, I spend a lot of time doing ethnographic as well as quantitative analyses of home care and CNA aides. They are the eyes and the ears. They pick up changes in condition way earlier than most other professionals. They know the behavioral issues. They know the emotional issues. They know the social support issues. Why are we not including them as part of the team? And let's not forget the family, by the way, which is the primary worker in this country. Families are not included in those teams either. You happen to be the major case manager in your situation, so you actually had to create your virtual team because nobody else was really there to make that happen for you. But in a system that truly was team-based, we would be starting with the person and the family And typically the first other professional who touches that person who is the aide. It is not the primary care doc who knows what's going on in the home. It is not the hospital nurse navigator that calls and has a clue about what is really going on in the home or the community. And somehow this system needs to be turned on its head. In the work that we're doing in affordable senior housing, we have a service coordinator for 100 residents who knows every single person. She's in their apartments, she's in their refrigerators. By the way, she knows every single benefit, every single turning of under every single rock, and she is the person who helps these folks figure out all the crazy fragmented system issues that you have had to deal with. She is the one person. In this model, we have a part-time wellness nurse that works with her. And in Vermont, we have shown a reduction, a bending of the Medicare cost curve, about $1,200 per person, with an investment in a service coordinator and a part-time wellness nurse embedded in housing for each 100 people. We're now also seeing reduction in nursing home placements as well, and papers coming out very shortly in, I forget which journal, but one of the journals we're doing this work with RTI. She manages all the other case managers because these people often have 5 of them coming into the building. Now, can we think about those kinds of models writ large in the whole community? We've already got an infrastructure. We've got AAAs in most communities around the country. Some of them are great, some of them are crap. But if we invested in that infrastructure, maybe we would see something different. And, I think this is the question that we have to come to at some point, and I hope the Academies really takes this on, which is how do we think about the framework that is set out there in the community? And quite honestly, the medical care system is only one part of it. When you ask an elderly person, an elderly, chronically ill, seriously ill person what they need, the first thing they're going to tell you is they need transportation. They do not say they need a better primary care doctor. If you ask people what they need in the community, they're going to tell you we need the supports to allow us to be as healthy and as functional as possible in our community for as long as possible. And somehow we got to start turning this thing on its head. I will tell you, I do a lot of work internationally. I don't think most other countries are that much better than we are in integrating social and health care, but they have a lot more spending on social care. And they also have a lot more focus, particularly in the Nordic countries and in the UK, on really looking at the community level and figuring out what will work in the community. The interesting thing for you is you came from a state that has a relatively very decent Medicaid waiver program, moving into Maryland, which has a great hospital global budget, but it has one of the worst Medicaid waiver programs in the country. So I'm not sure the global hospital budget is helping you very much, but certainly the waiver program, until you finally got something together, wasn't helping you at all. The implications for the workforce, as far as I'm concerned, are critical here, because this doesn't happen magically. Somebody asked about technology, and I'm sort of the Luddite in the room around this. I believe the last thing we have to worry about is integrated electronic health records. Not that we shouldn't have them. I mean, we've got the technology to be able to do it. We certainly do it in banking. We should be able to do it in healthcare. But the best interoperable electronic health records in the world are not going to be very helpful if we don't have staff that knows what to do with it or how to actually deliver good services. And we have spent relatively little investment in the type of workforce that is needed to create this kind of a framework and really have a person-centered, family-centered system. Paltry investment in one of the models that I think is probably one of the best in terms of thinking about holistically how you think about person-centeredness, and that is geriatric care. And I don't mean geriatric meaning we got to grow a whole bunch of geriatricians. I mean infusing those kinds of principles throughout how we get trained in our professional schools and in our in-service training in all of our systems. The other is, and I kudos to the groups, and I want to shout out to more because they've put a lot of resources into this, that we do need to think about if we're really going to talk about an integrated approach and a team-based approach, what does that mean in terms of how we really truly develop teams? What does that mean in terms of how our healthcare system invests in this, how our social service system invests in this, how our professional schools are investing in team-based approach when we're not incentivized to do that? What kind of clinical placements do we have? How many teams, how many students go out as a team into a home? I have had the opportunity, because I work in affordable housing, which is a sort of a microcosm of home and a community, to see an interdisciplinary student team embedded in senior housing at VCU, where these students are truly working together with all the different departmental disciplines, with aides, with the service coordinator in the building, and they are truly seeing what it is like to be in a team. They're going to take those experiences and carry it out into the real world. But we need tremendous investment in this. If you look at where our money is coming from, the federal government, you look at the HRSA budget and you look at the investments there, and it is a tragedy how little we have invested in the workforce that is really needed to do this. It is going to be human capital, at least for the foreseeable future. Everybody tells me that robots are running around all over the place in Japan. Well, I do a lot of work in Japan. I never see a robot. What I see is the Japanese system, which is 25 to 30% elderly, is suffering tremendously because they don't have enough workforce. They don't have immigration. They don't bring in foreign workers, and they are being strangled by the aging of their population. And I know immigration policy is for another meeting, so we won't talk about that here, but that also comes into the mix. So at the end of the day, Judy in particular, she's a good old friend of mine, and asked me to be incredibly provocative, and I don't mind doing that. I'm almost at the end of my career, and I hope I never need some of the services that I've been working on, because I have to tell you, I try to help organize this for friends, and it's just as difficult when we all know what we're doing. In fact, I think it gets more difficult when we know more. Ignorance is sort of bliss in this world, because everybody thinks, at least they think they're going to get something. They're not totally disheartened before you even get to the point that you need it. But I just want to conclude with, we have had decades, and I think, Lynn said this, we have had decades of discussion about integrated approaches. This is not new. We have a history of bifurcation of the medical and social care system. And again, this is not just in the United States. There truly is no system in the world that has a fully integrated social and medical care system. But I will say that many of the other Western industrialized countries do much better in terms of their investments in social services and social care, and they are trying to integrate more in many kinds of situations than we are. I think that the recent focus on value-based payment strategies that support financing and delivery integration are promising, but I think a lot of the investments have been put in the wrong place. You are not going to get community outcomes that are successful by continuing to put the money through the medical care system. It is absolutely impossible. I talk about the social HMO demonstration that was 25, 30 years ago. This was an old plan where you were going to bring social care together with medical care through social health maintenance organizations. There were 4 of them around the country. They actually did a halfway decent job of the financing, bundling the financing together. What they didn't do was integrate the services at all, and a lot of that had to do with the fact that these 2 systems were not working together. They didn't know how to work together. They weren't trained to work together. They didn't have the infrastructure to bring people together. So, I look around the room and I see a bunch of people that I've known for a really long time, and I see some people who are actually doing some of this in their own communities. I'm going to point a finger at June Simmons, because June does a great job of integrating social and medical care. But, why do we continue to have these sort of one-offs around the country? How do we bring this more normative? And I think the only way that we're going to make it normative is if we start to get investments in the social support infrastructure. Years ago, when I was in the Clinton administration, I once asked Donna Shalala, I was at AOA, could we have a fraction, and of the HCFA budget, could we have a fraction of it to help build up the social services infrastructure of the Older Americans Act, so that we could really do the person-centered work around this. And obviously it was a ridiculous request, and it didn't happen. And, you know, it may not happen. I mean, this is all vision, right? Because the details are where it starts to fall apart. I mean, we have a very entrenched system here that is really hard to tear apart. And it's one of the reasons why right now in my work around affordable housing, we're trying to get the Medicare and the Medicaid money to pay for the service coordinator and the wellness nurse, and maybe a little bit of capital investment to help with the affordable, because that's where the money is. But the truth of the matter is, and I think Lauren made just a fantastic point of, can we think as a society of how we want to really invest in this infrastructure? And some of it may mean moving monies around, you know, and that means on the federal level, even if we had all the stars aligned, the committees themselves, the committee infrastructure doesn't allow for these dollars to move between housing and transportation and Medicare and Medicaid. The people on those committees on the Hill don't hardly even talk to each other, let alone think about another way of rebalancing the dollars that we already have in the system. But maybe that can happen at the state or local level. So because it's got to happen at all different levels. And finally, I would say that let's never forget the person and the family. I think, you know, we started out with a fantastic journey, which is, you know, you're not unusual. You're incredibly lucky. I do want to put a plug in for home modification. It is one of those social investments. And I know Sarah Stanton is in the room. The capable model is showing very positive outcomes for healthcare savings, better quality of life, and functional outcomes for people who actually have a combination of home modification, a little bit of nurse management, and an occupational therapist who helps people to understand how they adapt to their environment. So not everybody needs to build a whole new 2-bedroom suite. They also can look at home modification and adaptation and how that might actually help a lot of these issues. How do we get that paid for? And then are the incentives in the right place? The craziness of a tax credit that you can't get because it doesn't go through your front door makes no sense. So, you know, that's the devil's in the details. How do we bring this all together? And I would say that Montgomery County probably needed to have some end users together with them before they developed their tax credit program. My guess is they never talked to an end user when they set up that program. So I got a couple minutes, so I'm going to stop before, which is kind of unusual for me. I do want to say that I think we've got the Academies is a great place to have a bully pulpit. There is a new consensus study that's going to be coming out around the social needs aspects of healthcare writ large. That is a major step forward for the Academies. And I just hope we don't have another meeting 10 years from now where we're talking about the same thing. By that time, I'm going to be almost 80, if I'm alive. And I would hope that we would actually move a little bit further than we have. And I wish us all luck. So thank you very much.